This talk is based on my expertise and what we have done for the past few years in understanding the physiological signals and how it can be applied related to healthcare. So, what we have achieved or what we are working on towards achieving applications related to the healthcare and how we can give to the society and in relations to attracting more researchers into this particular field. In order to start with, I have been working on this particular field of physiological signal in various applications from the last few years. I have given this talk with respect to an outline of this talk with respect to three different types of applications in particularly in physiological signal related to cardiovascular activity, muscular activity, and as well as how the applications can be related to the Parkinson disease, more towards the rehabilitation point of view, and as well as providing a solution to or providing an information related to what happens within the physiological signal or physiological activity. Um, as an introduction, I think most of us, I'm just giving you a brief because of the varied audience related to the physiological signal system. And we term that as a physiological system which performs different types of operation, mainly in terms of where you can able to manipulate in response to one or more inputs, which gives rise to one or more outputs. So this system is based on, you can able to see here a system related to the sensory input, so which is based on integrated with the brain, and then it goes into the motor output. So where we have this complete system, what we call or term as a physiological system here. So both physiological as well as the physical system. Physical system is the one which will based on the input which will be activated. So these generate an highly complex output signal. So we are only recording the output signal from the body or what happens due to a particular input. So it can be one input or it can be in response to one or more inputs, which gives rise to many outputs with respect to this physiological system. So in order to understand this complex output, so what we need to know how this complex output has been related to the physiological response. So we may record any type of a signal, either it is an ECG or EMG or EEG or any signal you can able to record. But how I can able to see related to the reason why I am getting this output. So for what reason the output is varies. Even even if the person is healthy or even if a person is due to some reason, if he is having any symptoms. So how this complex output is varies with the response to any one of the physical system here. So the inherent feature of these signals mainly is mentioned as a non-stationary and defined as changes in their statistical properties, not on the direct properties. What we say in terms of a mathematical term. So and also it changes over time. So that is why we want to see a time varying signal with respect to how it happens with respect to any of the response to the physical system here. So the Birkin et al. In 2014, they defined these signals or defined as changes in the statistical properties over the time. So we need to take that as an information while we perform any types of analysis into this particular physiological signal properties. So the main aim is to understand these measurements and how it is being changing with respect to the response to any kind of symptoms or any kind of a process. So there are many physiological signals that are produced by the physiological process of the human beings. We termed as heartbeat rate is an ECG signal, and the respiratory rate. Why I'm using these terms in terms of rather than using ECG or EMG, because this is what we are going to extract the information from the actual biological or physiological signal. Then you have a skin conductance, muscle activity, and the brain electrical activity, which is the electroencephalography signal. So we will see some of the examples what how it is being received or recorded and how it is being analyzed. So, as most of you know about what is the ECG, in recent times, ECG has been extensively researched. Many theses or many research papers has been published or reported in terms of analyzing the ECG in different modalities. So, ECG is being more used by researchers in recent days to investigators seeking to get better understanding. So the point is, still we know that once the ECG machine has been used to record the ECG signal, so but still we are you can see that how many number of papers is being published, or how many number of reports, or how many number of devices have come off into this understanding this physiological condition. So it means that still there is a possibility of new discoveries once you try to understand. So what happens in this point is how we are uh, identifying these understanding by extracting the information. So each and every researcher comes up with a solution by extracting different kinds of information in different types of domain, either in the frequency domain, time domain. Then you have time frequency domains, and then you look into the complex structures and how we can able to get this complex structure into this. So in order to understand this point, so you every researchers going through in terms of the ECG signal, you can able to see the point. So how this particular ECG signal has been recorded, and what is the each point of the signal, how it is being generated and how it is being recorded. So in order to get this particular or noise free signal, so we will be using the electronics to get the signal, and how there are three types of three parts in which you have sensor, then you have the electronics to record this one, and then you have filters. So and then you need to get the exact information of what the heart is trying to tell you in terms of the output what you get, because this is the output of the heart you are getting. So this output is what you are going to see how there is a change in this particular shape of the signal, or the time of the signal, or what is the duration of the signal. So this is what has been explored in the last few or many decades. They have been studying about this. So the main in this is not just recording the heart rate would be enough. So that is why they started with recording just the heart rate. So heart rate is like the beats per minute, and then they looked into the signal. Once the advent of electronics started to increase, then we received this signal, ECG signal, and we had this signal in our hand to learn something new about this heart rate. So it gets the best insight obtained through analysis of this particular data. If you see here, the point here is, when understanding the heart rate, the more informative relies on this metric. So just so more relies on this, not just on the heart rate, but how the heart rate varies. So what it means is, so first they started working on the heart rate. Now you can able to see that in last like 10 years or 15 years, every other paper or any other report or any other device, even now you have an app from your any smart device which calculates this heart rate variability, because more it culminated from the research which was done like a few years, where the higher heart rate variability is associated with the good health. And in 2000, they had a in a general population, with the data collected from previous 10 years of data which was collected from the patients, and they came up with this, those who were the population, in general population, those who had this coronary heart disease and those who are having higher risk of death, or they had a heart disease. Due to that, they in the elderly patients, they looked into the heart rate variability of these patients. So why they had this heart disease, or what is the reason? Can we able to identify the symptoms? So they all had a low heart rate variability, which was recorded but was not investigated more extensively when this heart rate variability was started to identify as a metric in terms of coming up with the solution related to uh, the heart diseases, and linking the heart disease with the heart rate variability. So this one, based on previous general population, they have reported in 2020. So it is sorry, in 2000. So last 2 decades, they started to work on the heart rate variability based on how we can able to link it to the physiological condition. So we know that what is their main. So they looked into the QRS complex. So this is what we call as a QRS time interval, which gives you an information related to. So many research papers, if you come across, they try to understand this QRS complex, or they try to what you call extract this information from the analysis, and they and it is been more important corresponding to different part of the heart's action. So this QRS becomes more important in terms of the QRS, in terms of the heart action related to this. So that's what we have seen here. So you can able to see this heart activity. So each pulse, when there is a contraction and the relaxation, you will be able to. So QRS is a one particular complex when compared with the other segments. So here it is a simple example to show how the heart rate is being different from the previous, what we call as a um, uh, just the heartbeat. So you can see an example here. I'm using a time domain signal to analyze this particular frame. So there are how many heartbeats in this particular frame based on the time interval, and then I'll go into how many how are intervals are modulated in the sense how many are modulated in terms of the frequency of our intervals. So because the time is one, and you can see the difference in time here and as well as the time here. So this becomes your RR interval. So RR interval is the. So now the importance of the QRS becomes very significant in identifying this R segment. So you have RR interval here. So the interval of time between the one peak of R to this. So this one is, I'm just looking into number of beats, 1, 2, 3, and you have up to, for example, 10 beats or something like that. So frequency methods count amount of low and high frequency. So it means that this, I can say that how many are very close and how many are very far. So this frequency will give you based on the methods. So you need to find methods, frequency domain count, how many are low and high frequency beats. So just by looking not only about the heartbeat, how it is different from looking into a different domain. So this is where the research is being going on, from how it is being advanced. So if I want to do in terms of a time domain here, a single most common way of HRV is the RMS of the standard deviation RMS. So you take this. So mean of the above will give you the RMS standard deviation. So you're taking the interval, not just the interval here, and you are taking the difference in the interval between this interval and this interval, and then you are taking the square of this, which will tell you about this information about the difference in the RR interval within the time period, and then you take the square root of this square, then you will be getting this RMS standard deviation. So RMS of successive difference. So you will get this RMS root mean square of the successive difference. So this root will provide you about the root mean square of success between the heartbeat. and it is relatively simple to calculate, and provides the reliable measure of our the HRV. So HRV is nothing but the heart rate variability in time domain, which gives you information about the RMS SSD here. So we calculate the successive difference in order to see how the difference varies with respect to the time here. So you can see the difference of the time RR interval changes with respect to the time. So now, for example, I'll take a difference between the average RR interval. So which is the RR, I take the RR interval time intervals for this particular example, and then I take the average of this RR interval. So now you see that this uh, range is particularly different. So you can able to see, but for the heartbeat, for both the cases, the heartbeat is same. Both the parameter, the heartbeat is same. But when I record, because it is not necessarily that a healthy person or the normal or any symptoms who has a symptoms or a patient, they might have the similar heartbeat rate, which is nothing but it gives you 92 beats per minute. But the interval between these two may be different if there is any symptom. It means that your heart functioning, it gives you the beats, it is pumping and it is contracting and relaxing, but sometimes it is too fast or too maybe too the time intervals within the time it is changing. So now here you can see that mean RMS in terms of it gives you 31 for the same beats per minute. You have a different rates. So why is this happening? So if I want to just take with respect to the beats per minute, this is one condition A, and this is a condition B of an ECG. So you can see the difference if I am only taking about only the beats per minute interval. You cannot statistical, no difference has been able to identify. So what will happen here with just only the beats per minute, I will not be able to get the information or between the two different conditions. Okay, and now here we can see that more it can be now. This based on this RMSD value, I can able to more physiologically see that the condition A has a lower HRV when condition B has a high HRV. So higher HRV means lower HRV is associated with the more physiologically arousing. It means that it is not varying to the condition B is varying much towards that stress response. But condition B with the similar stress response, it is not varying much. So this is what we have two different conditions where in one particular case we are not able to differentiate, but in another domain we are able to differentiate in this particular in this sense. So the aspect of this shows that the aspect of looking the same signal into different domain, or even if it is in the different uh, uh, different response, you need to correlate with that, physiologically correlate with the condition which is related, why it is this condition has happened between A and B. So that will tell you information. So that is where we want to analyze the data here. So the frequency domain methods, we try to see that what is the frequency as a measure of because it has been already shown in the physiologically that the sympathetic nervous system will be related to data, related to the amount of low frequency is often as a measure of the sympathetic nervous system, and very low frequency is also used in terms of the particular case. So if I find the ratio of high frequency by low frequency, then I will be able to determine the amount of the nervous sympathetic nervous system. So it means that how the stress activity or any kind of a stress related to in your body. I'm not talking about the stress related to the your mind. If there is any organ which is stressed to function, that will be reflected in your heart activity. So this is more important to understand the different types of the measures, or the metrics in which you are going to analyze it. So the other one is a point care plot, which has been now used for the HRV, which gives you this is kind of a data visualization where you can able to identify the different. So this was introduced by the French mathematician, name called point care, and he was using for different terms of to look into the variations in your condition. So based on this, the RR interval, how we can able to view, because you will be having I may record for a person like more than 30 minutes of ECG, or more than to see how it is being recorded. Okay, so this will be simple. Sorry, yeah. So here we can able to see the difference in the point care plot, how it has been plotted. So this is plotted within the time interval of first interval versus the second interval. So RRN versus the RRN plus. So you are trying to see between the two consecutive intervals how the change has happened with respect to the condition. So you can able to see that the greater spread will show you that there is an increase in the HRV, and while the closer spread, from here the graph, you can able to see that here it means that your HRV has been increased because the difference between the plot between these two, the values will be changing. So if there is a not much change between these two intervals, you can see that there is a less HRV, which can be able to. So with this, you can able to understand the process in terms of the limited heart variability or higher heart variability, and how we can able to relate it to your the condition. The standard point care plot is related to, so you can able to see I and I plus 1 here, and this is the standard rate in terms of. So this spread from this point, you create a dispersion ellipse. So in this spread, you will be able to see what is your two different dispersion from the center line. So from the center line, two different dispersion happens. One is SD1 in terms of along the minor axis, and along the major axis, what is your SD2. So this is your minor axis here, and from here, this is your major axis. So the change, this point, the dispersion of this is termed as SD2, and the dispersion of this is termed as the SD1. So this will tell you information related to the. So why we want to see this in terms of any kind of any kind of a response, because this will provide you information related to any parasympathetic nervous system change in the sympathetic nervous system. So where you can able to clearly um, try and visualize the data here, not just by looking into either the RR interval, or even due to the heartbeat interval here. So this started based on the particular condition, the cardiac autonomic neuropathy. So if you have heard about this, so this was recent, or it is there for a longer time when the diabetic patients started to increase, they started to notice this cardiac autonomic neuropathy. Uh, uh, Cardiac autonomic neuropathy started to feature in the patients when the complications of diabetes started to increase. So what happened? It was underdiagnosed because they were not, even if you go for a doctor, and in early stages it was underdiagnosed because it was not related, clearly related to diabetes. The diabetes, once you started to have this the diabetics issues, and then when you go on continuing with your medication for longer time, or also if there is any change in your lifestyle or anything, then it reflected in your cardiac activity. And because cardiac activity is also part of your muscle related, because heart muscle has to work, which is connected to the neurons. So this is started to show in the heart condition, and that was related to cardiac autonomic neuropathy. And many diabetic patients of the long duration of the diabetes, they start to, by the time they find this symptom, and they are already, their heart function starts to decrease. But it is still, now it has been more improved, because every time we can able to see that, we can able to see that the heart, we can able to, the heart conditions, if there is any, you have your hypertension, or if you are looking into the diabetic mellitus condition, this autonomic started to come, and then is how this played an important role in this and a substantial role in the patient's uh, 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 diagnosis. They looked into the duration of the diabetes, and also this glycemic control. And how, so now if I want to see, since it is related to cardiac autonomic neuropathy, which is a heart related, and this is related to now with the ECG, whether I can able to see the I can able to diagnose it early, or see the symptoms in the ECG, or take the parameters in the ECG before the condition. So this is the work we have done recently related to, so many symptoms related can be seen in diabetic patients, and it is very silent in the early stage, and suddenly it starts to proliferate faster and increasing the risk of mortality in the diabetic patients. So that is the reason whether we can able to identify in the early stages itself. So we did a simple, the previous study has been done for the last 5-10 years, related to using this point care plot to identify the can condition, uh, 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 how it can be able to see, particularly in the diabetic, be able to see particularly in the diabetic patient. Started working on looking into the RR interval, which has already been seen. So mostly all of these looks into the particular case of R peaks only. So they are looking into the QRS complex because of the complexity in analyzing it. It is looked into as an R peak interval. So we have this condition. So what will happen? Uh, this condition. So uh, other segments, because we have ECG with the various other segments. Sorry for. So these segments, can we able to see in particularly in the PR or any other QT segment, or all the segments in the ECG, because they, instead of just looking into these segments, so can we able to identify the same interval, the time interval where there is a change, because you want to see we would like to see the change in the uh, each of these heart rate, because every condition is related to a particular functionality of the heartbeat. So we want to see how this changes with respect to a normal condition, and we collected a data with respect to early can, and this is a definite can, and we had a severe can. So based on, now we can see this point here, the definite and severe can had the same time interval, but you can't say that with respect to this we were unable to see what is uh, the um, the difference between normal and early can. There was a little bit of changes in this one. So this basically on the ECG system, ECG signals, just looking into the time, we were not unable to, we were not significantly able to see the time difference in this particular case. So what we did is we tried to analyze, this is the the interval, the complete interval, because we recorded for 30 minutes of data. So this is a sample 30 seconds, the 300 seconds of data we are showing. So this is the interval. So we want to see the change, how complex is this particular waveform. So how complex in the sense that how the change is happening very frequently with respect to the time, because while sleep you will be able to, this is recorded while sleep. When you are at rest, your heartbeat will be more response to the organs, because all organs will be in the rest condition. So in that point, if there is any issue related to your underlying issue related to the hypertension um, or the diabetic, what will happen? There will be a change in the variations here. So in order to check these variations, we calculated what we call as a complexity of this waveform, which will show you as a fractal dimension. So the complexity is the self-similar structure within this change, and we computed the fractal dimension for this particular signal to see whether the dimension in this, due to the complexity, whether the dimension will change and how this change happens within the waveform. So now we are applying a mathematical concept into this. So here we were able to see, still in this particular point in the we were looking into do all different segments. So we can able to see that in particularly, and there are papers which related to this particular can disease showed that we have uh, uh, that RR segment, and also in particularly ST segment will be showing you this change where the variation happens within the for any, if you have any condition related to the neuropathy condition related to the heart activity. So we were able to see this. So what we did is, instead of looking into the whole 20 minutes of data, we divided that into every 5 minutes to see how the change happens within your sleep interval. So this was recorded for 30 minutes during your sleep, and we were trying to see that how between the time interval, how this has been changed, or is there any change with respect to the time, to show, instead of looking into the overall signal, which which may not give you a better analysis with respect to the identifying the symptoms or classification. So we did a simple, since the data was not normally distributed, so you can able to see that we did a non parametric statistical test. So you can able to see here all most of the signals, most of the FD values, which is the fractal dimension values, were significantly differentiating between the intervals in respect to either of these intervals. You can able to see that. So further investigation has to be done why it is happening in this particular ST interval, because already the physiological changes has been reported in some of the papers. So we need to identify these changes, physiological changes, and why it is happening in this ST interval, which can be correlated with the condition, underlying condition, either if it is due to hypertension or due to the diabetic condition here. Similarly, if you see the just only using the time interval, which is your including the RR interval or other time intervals, we were unable to see any significant result with respect to that. So this study was published in the Applied Sciences Journal. So which, and also we received a news article based on this work, where we use this fractal dimension to demonstrate that we can able to see the change in the heart activity due to the cardiac autonomic neuropathy. So we implemented this system so now the aim is to, now all the all the research has to come from bench to the bedside. So we want to see whatever is the laboratory condition, and we want to see that in the bench side here. So we created a small device to see that this is the first version of the prototype, where this work was done along with my research scholar, and this is where the patent application has been some published. So we are waiting for them to grant it so that we are currently looking for testing it with the testing with the hospital to take it to the next level. We have done the preliminary analysis. Now it has to go to the next stage to get it to be done. So this is one of the the what we are trying to look into analyzing in a different aspects. So where you, instead of looking just into the segment here, so we want to look into how the variation happens within this interval in this point, and try to see that how we can able to bring in not just to the analysis part, and try to link it to the actual physiological condition here. So just I want to show you here. This is the graph, like a visualization graph, what we have seen in terms of a heart condition here. So here we can able to see in this particular uh, case. So based on this, you can create a map. So this is your visualization map from the features, contour map, even with the RR interval. So not by just looking at the graph, you can able to see that same determinal inter beat interval time series. You can able to see, if so you can see that the normal typical atypical flutter happens once or twice here. This is the normal, but if there is any stress happened, so you can able to see that that will be changing into a different zone where the activity will be uh, analyzed in this case. So you can see here. So based on this normal condition, you can able to see this is the normal typical case. So you bring in into the different beat interval. So if you see here, if there is many flutters happening, this is your based on the anatomical location, the flutter happens. You can see the number of flutters. So that flutter can be seen visually from the ECG what you have recorded due to this condition. So this will give you any clinicians to look into the uh, transformation of ECG to this case, or looking into the to get more insight into your data. So this is related to ECG here. Uh, we are happy to collaborate for this particular data. If you want to have, we have a database to work on, so that many more insights can be received in this particular case. I think I have some. Next is I'll just rush through this particular point in terms of muscular activity. The next what we discussed, what we were looking into the physiological point of view is the muscle activity. So next is in terms of rehabilitation. Now we have everything related to your ergonomics or gait or your walking pattern, or because of your long sitting down or standing in your work condition. So this is, so you can able to see here. So I'll get an input. So this is your sensory input here. So I get an input. I think that this is, I want to lift my hand, and then this is connected to this point. So each and every muscle is connected to the number of neurons. So which will be activating your muscle, and this in turn your flexes your total part which is connected to this particular bone. And this is very important in terms of analyzing for the rehab condition here. So nowadays, this is not been critically used in the clinical side, but more recently, any neurological or physiological physiotherapist are trying to look into the responses for their rehabilitation, to look into whether they are improving in their rehabilitation, or what happens and which muscle is getting activated due to this reason. So looking that into a different perspective gives you a more insight into this the neuromuscular active condition here. So So I'll just rush through this one because the electromyography is the recording records the movement of muscles, and EMG activity is linearly related. So EMG is your linearly related to your muscle contraction. So this is what generally they say that, but sometimes your signal is non-linear in terms of your other, because you have many factors related to this muscle contraction, and you are recording from the surface of your muscle. You're recording on the surface. So there are filters within the skin. Your skin is a filter because your signal has to reach on the surface. So this all depends upon your how you amplify the electronic the system in your signal, and what is the electronic system you use. So because we are recording the voltage amplitude which you receive on the surface of the skin. So I would like to acknowledge Professor Roberto Moletti, so whom we have been in collaboration for last few years. So he is the one who started working last 30-40 years related to this EMG, and some of the materials I'm using in this presentation with his permission for understanding the points and where we have collaborated with him in terms of the research. So uh, what is an SEMG signal? So first you need to understand what is the surface EMG signal in this case. So you can see here, so this is the number of motor units. So what you see in this particular point is the connected neuron and muscle. Each one will have its bundle of fibers, and bundle of fibers will be connected to the number of motor units, which will be activated based on the pulse received from the body. So this one is generated. So this is what we call discharge of motor units in the muscle. So each motor unit will have number of muscle, and this is what being in travels. So this travels across the fiber or motor unit fiber. In each of these, each fiber will have number of motor units. But we are trying to say that the motor potential is being adding up algebraically on the skin in the point, because you will be recording on a particular point here. This is your direction point. So SEMG at this direction point is a combination of, for example, this is my muscle which is being have, and I am placing the electrode here, or two couple of electrodes here. So this is your detection point here. So whatever I get to near to this detection point, and this is what we are recording in the SEMG as an SEMG. So that detection electrode can be different. Either it is a monopolar, or it can be a central electrode, or a double differential, or single differential. I'll just show you. So for this SEMG surface signal will have different features and different detection points, because your motor unit, this is what we call as a motor unit action potential. So this action potential have a different amplitude, because if it is coming far from this point, in order to reach this detection point, your shape in the amplitude will change with respect to different detection points. So that is the reason your most of the clinicians or any physio, they sort of try to avoid using this because of these more uncertainties in this particular. But now it has been presented in a more different approach. Each and every EMG signal is being presented to show that how it can be uh, visualizing the what is inside, what is happening inside the muscle. So this is your original law signal. How the amplitude of the signal will change, because this is one of the feature which is being used with respect to the contraction. If my contraction is more, so what will happen if I take the mean of this particular signal, of the raw signal, it will be zero, because it will be the combination of all. So this will superimpose in terms of this. So generally the original law signal, if I take, it will be close to zero. So that is the reason in most of the EMG papers, if you see, they will be looking into the mean absolute value or average rectified value to get that during a particular duration of the signal. Because if you take the mean, of this raw signal, this will be considered as a 0. Then if I want to look into more the mean of the signal, then we look into the root mean square value. So where it will gives you, so we want to see how the activation is happening when muscle is getting activated. So you want to record that. Once you record, you want to see how it is being um, uh, how is being reflected upon in terms of your activity, and how it changes with respect to different activities. So you can be able to see that that is the reason they look into this is the raw signal. You take the envelope of the signal here. So this will tell you that the activity of this particular muscle, where there is, if I'm doing a very low activity or very high activity. So sometimes they use this for identifying from this point to this point. So I'll take an area under the curve to choose. So what we call as integrated integrated of this envelope to get the actual activity happening within this region. So not, so this point is, if I'm looking at only at the raw signal which gives me this amplitude, I will not be able to get any particular insight into the data. So each of these will be providing either envelope or RMS. This is related to the how high contraction is happening or very low contraction is happening with respect to the muscle activity has been done. So why we are looking to muscle activity? Because every pain related to muscle or every physical rehabilitation is related to how the muscle gets activated. Similarly, you can able to see that this envelope also can be processed by having the um, uh, a simple A to D conversion. So this is the actual signal. Then we pass it through different types of filters based on the condition. Now we can able to see the more clear way of here. So why we are doing this is based on, because I want to see if a muscle is getting activated. So if you can see here, I can't find the exact point of where the activation started. So what we call that as an onset. So there are many papers to or publications to see that when the onset happened and when the offset time is starts. So in order to identify this, you may able to see that in some this will be the incorrect estimate of offset time, because that will be um, 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 that will avoid, that will make that questionable value of this offset time. So that will try to incorrect measurement of your other features. So it is important to see that how we can able to get the better of onset time and also the offset time to see the activity of the muscle during this particular interval of time. Okay, so this has been reported for particularly for to understand these technical aspects for clinicians. So mainly to make them understand how this can be used for analyzing the data for any kind of a rehabilitation for low back pain or ergonomics or any other muscle activity related conditions. So the question comes is, that's what I said, where would you place this time, offset time in this particular case? So it becomes very difficult. So now we need to look into a different aspect. So here you can see that what is SD here means a single differential. So I take a single differential of this particular, this is your recording site. So a particular muscle, and where I want to estimate this activation to find the activation timing, and this to see that the envelope is influenced by the electrode location. So this is your biceps muscle, where I try to shortening means I'm trying to do some kind of activity, and then you are trying to record. This is your location of electrodes. I'm keeping 3 electrodes with a distance of 25 here to see that this is your. There are different types of electrodes. Either you can use 15. 25 is from center to electrode distance, and the diameter of this will be, so based on that you can I can able to compute the difference in this, but in this case. So you can able to see the two different EMGs within this location, proximal location here. You get a different activity. So this is to look into various types of signal in terms of understanding the points of different locations, how the envelope will be influenced by the electrode location here. So you can see the point. So where if the elbow angle changes from 180 degree to 90 degree, we are recording this EMG signal from two different locations points. So based on this, you can able to see. So this will tell you that the envelopes may change with respect to 1 to 2 is a signal differential electrode, and 2 to 3 is another signal differential electrode. So we need to analyze, if I want to analyze the more clear picture of understanding how the muscle activity starts from one position to other, you need to have different many electrodes which will record this movement of the muscle during this during any activity here. So this is the point in looking into different aspect in this case. And then you go for different types of features, the frequency features, which can be able to identify what is the mean frequency and median frequency. So this is an example of a CMG power spectrum to look into how this change in frequency will happen with respect to the activity, not just in the time domain. So which will be denoted if there is a, I will show you that there are many indices why we are using this for this case. So there are many indicators of fatigue related spectral compression happens. So fatigue related is your muscle fatigue related. Uh, uh, Most of the papers, if you can able to see, there is a change in your median frequency from when the muscle gets fatigued, it goes to the lower level, and it is more. We can able to see that when you are normal. I'll show you an example in the next slides. So the median frequency reduces when there is a muscle activity, or when there is a fatigue in your muscle activity. So due to some kind of an activity here. So that is why the mean or the median frequency is being used as a indicator for to show the spectral shape. So this is in one aspect, because you can't see this fatigueness in the time domain. So that is why they looked into the frequency of, because that frequency is related to this particular sorry for this particular number of discharge happens within this range. If there is a fatigue happens, your number of motor units gets recruited more in order to compensate your fatigueness in the muscle activity. So that is the reason your frequency will change. So that frequency can be able to see here. So you can see that at the beginning of the cycle of an exercise, and at the end of the cycle of an exercise, you can able to see the first epoch 1 and epoch 2. So first epoch, the frequency mean spectral is closer to this point, which is your 100 closer to this point. Okay, and when you have epoch n, which is your final, this main thing goes reduces, the frequency is in the which goes to the lower band. So this you can able to see that, but the spectrum slowly changes in changing in time. So based on that, I can't see the whole signal. As the time increases, this will starts to change with respect to the muscle, how the muscle get the motor units gets recruited, and how based on the load, how much you are able to carry. So this is how we are looking in a different angle to look into the aspects. So this is what you can able to see here. The more clearly the power spectrum signal happens in terms of the power spectrum signal 2, where there is a sustained fatigue happens in this particular case. So this is in your pre-fatigue. So once it starts to fatigue, you can see that the power spectrum moves from this location, this point to this point, which is your main thing. So this why I'm looking into the muscle activity is we need to apply this to a particular to an application. So what we are trying to do is here we are understanding this EMG. Now we try to apply this in the Parkinson disease patients. So what will happen is, because it is a neuromotor disorder with a gait impairment and they have a poor posture. So they have a shuffling gait. So how this is related to making this the muscle to go more, how we can able to strengthen the muscle to avoid these kind of gait conditions with respect to. So we want to see how and each and every what do you call the steps they take, and how it affects your muscle activity for a normal person, and as well as the once you are being diagnosed with the neuromuscular disorder such as Parkinson disease, and now uh, where we can apply this to the rehabilitation to increase their muscle strength so that they can avoid this uh, what we call as unsteady gait due to the reduced strength. So how we can able to increase this strength, and also to avoid making them life more comfortable. So this is where we try to use. So in order to look into this, we looked into different types of muscles, because either we say that whenever there is an action, there is an equal and opposite reaction. So here, even in the muscle, once it pulls and other one tries to resist or attach, and what we call as an agonistic tries to help into. So what we call as an agonistic and antagonistic muscles around the ankle, which is referred to as. So we want to see how this activation and how we can be able to improve this activation with respect to some kind of an exercise providing. But excessive activation also provides your, because excessive means if I am giving the co-activation more from the antagonistic muscle, then it can able to produce the negative work, which can also increase the rigidity. So we need to make sure that this is in the balancing condition, so that we can able to understand this co-activation index. So in order to do this, we what we did is we calculated or we measured by analyzing the EMG of the opposing muscle, uh, so that we can calculate this co-activation index to identify what happens. So what we did is we recorded this particular two different muscles. So tibialis anterior is the total where it can be able to identify the activity, and this is TA, and one is the antagonistic for different working condition. So there are two activations. One, what we call as a co-activation index, which will be overlapping and based on the area of the muscle. So we calculated with respect to that, and so EMG is overlapping area. Based on this, we calculated this CI, and based on the condition, the modulation index was computed. So based on the EMG maximum minus EMG minimum, and we are able to calculate the maximum is nothing but is not from the raw signal, from the root mean square, because the raw signal mean will provide you the difference. So based on this, you can see the average profile from the walking condition. This is what we call as a gait cycle. From the first support, double support means you will be both the legs will be on the ground. Then you are lifting it, single support, then second double support. Then you have a swing, then you will be going for the walk. This is one particular gait cycle. So you can able to see that the cycle in the blue is has a very low support system in terms of the normalized EMG condition. The strength is very low here. But when you consider the control patients, you can see that the strength is a bit high when compared to the different gait cycles. So that is being reported. We recorded the age matched control because both are in similar age group, and then we have a young control group here. So we can see that young control group, the gait cycle, this is your CI percentage, the mass area of the muscle activity. So area of the muscle in terms of your normal area, which will have they have the highest area because this is, but they the when compared to the change will happen in terms of the different gates cycle. So different gate cycle, your muscle area means it is not about the muscle mass, how the contraction, when the contraction happens, how this area will change. So that is what being recorded in this particular case. So you can see the difference in this area. Now we relate this coactivation index with respect to the average profile of this particular PD. So where you can able to see the difference. So now if I am able to reduce this, give the strength to the activity, based on the coactivation index, and as well as by giving an exercise, I may improve on this particular action by giving them the rehabilitation exercise, by giving them strengthening that particular muscle, where they can able to avoid this because we know that this neuro disorder will is it's once it happens, it is not curable. It is it's a disease which we don't say it as a disease, it's a disorder. So which cannot be, which can only be maintained. So in order to do this, we need to provide them the feedback how the rehabilitation can be improved in this condition. So that is why we have used this condition, use this research to work on that case. Next is we know that we are working on the wearable sensors in many of the condition. So in order to see that how the tremor affects the people in terms of the healthy and control, and because essential tremor is one of the initial symptoms of any kind of a stroke or neuro muscular disorders, or neuro any kind of a neurological disorders here. So we have used a simple technique to record based on the time, so we can able to see the essential tremor participants. So this is related to nothing to do with the real physiological tremor, but we saw there is a change in the location of the sensor. So we can able to see the location of the sensor. So that is change with respect to within the change where so you can able to see that sensor 3 has not much tremor happening, because this will give you an information where the neurological disorder happens, or first has the symptom. Based on the symptom, they will be providing you, because before it was like a subjective analysis with respect to the any clinician. So this will provide you an information related to this any kind of a device, and also this can be connected easily to a patient when he is doing an exercise, to see how the tremor affects in different parts of your thing. And also based on, so we try to look into the task time, what is the task time they have done. And also this is FTM is your uh, frequency of the movement, which is recorded by the clinician. So we try to link this physiological with respect to whether what we are seeing in the physical response is coinciding with the what the clinician is noting down based on the gold standard, so that this gives an additional information related to this particular condition. So this has been submitted published in scientific reports, so which got a wide result. So we are planning to develop a device with respect to as a wearable device, where it can be used for complete analysis will be shown in the dashboard to show that what happens when there is a tremor, whether we can able to differentiate between the different essential tremor, whether it is due to Parkinson or due to any other condition, based on the location where we have tried to record it. So this is related to the looking into a different aspect, just look into the different positions of the location. And this just to show you the example of here. So I want to show, this is from, so this is the visualization we used to record. This is the initial like 10 years before where the when the electronics was just show you again. So you can able to see that visualization. Before, doctors were not unable to look into these ones. So you can able to see when just by long standing, you are standing longer for a quiet standing, how your muscle gets activated in your back. So if there is any stress in your back, this will be changing with respect to the particular conditions. So this is what will happen in terms of this. You can able to visualize it, because unless you look into even ultrasound will be showing, because you have to try to see this condition in this point. So this will give you a distribution of the data looking into this particular condition. So another example in this point here, you can able to see this three different angles where you are bending. So based on these three different angles, you will be seeing the change. So if I'm straight, how 80 degrees, what will be the condition? So if there is a more activity, you can see that the activity, based on the activity, the color change will happen, color coding will happen with respect to that. So if I'm stressing more, then you can see that how the muscle gets stressed, and you can able to see this in particular point. So this is the way we look into the, and we convince the clinician to see and how we can able to analyze the data in a different aspect. Um, uh, with this, I come to an end of the. This is some of the references. I would like to acknowledge the work of some of the following team members. I predominantly work with this university in related to all these conditions, research work based on the data and everything. And I would like to acknowledge the, the team members from different labs. Thank you for your patience.